Hi, I'm Shannon Griffin, and you're tuned in to Chatterbox here at Hospital Radio Medway. Now, I recently had the great pleasure of interviewing Jayne Black, and she is the Chief Executive Officer of Medway NHS Foundation Trust. In this first of 2 episodes, Jayne discusses her role and responsibilities, the scale of the operation here at the Medway Maritime Hospital, and her career route to her current role. I'm Shannon Griffin, and you're listening to Chatterbox. Now, my guest today is Jayne Black, and Jayne is the Chief Executive of Medway NHS Foundation Trust. Jayne, welcome to Hospital Radio Medway, and thank you so much for your time today. We really do appreciate you taking time out of your busy schedule. One of the first things that I thought might be useful for us to understand is the kind of scale of the operation that you lead. What are the sort of numbers that we're dealing with in terms of hospital running and all that sort of thing?
So we serve a population of around 450,000 for both Medway and Swale. Mm-hmm. So it's it's a reasonable size trust that's looking after the healthcare needs, if you like, of that area. We see around about 130,000 people a year through our emergency services. So you can imagine that's really busy. We see about 5,000 babies being born.
Goodness, that's quite a lot.
So it is a lot, and it's growing, and I think it will get more as time goes on, as more more houses are built, etc., etc. Mm-hmm. So we are very, very busy. We've also got elective services. We see quite a number of admissions over the year for both elective and emergency. But also we're increasing our number of patients that we're seeing through our day case unit, which we have now preserved as a day case unit, and also the number of operations that we do. So it is an extremely busy place.
And in terms of finances, what sort of budget are you responsible for?
So we're sitting around about 460 million. Depends on, what funding we get at any point in time, but it's roughly round about there.
And how is that changing? Is the government keeping up with providing enough funding, or is there a shortfall? How do you manage all of that?
So at the moment, you will see, and you would have seen it in the press, that we have a control total, as we call it. So we are in a deficit at the moment. Mm-hmm. And this year we are at 29 million, and that's what we're planning to be at to maintain the services. But over the next few years, there is a plan to get down to break even, which is really important. Unfortunately for Medway, as many other places, we've got an underlying deficit, which has been there for quite a number of years. So we're working really hard. Mm-hmm. The staff are working really hard to look at services, how we can do them the best we can do, maintaining quality at the same time. Yeah. But actually, how can we improve those services and be as efficient as we possibly can, and driving down the cost?
Do you ever feel as though you're spinning plates with all the responsibilities that you have?
All the time. All the time.
And what gets your attention the most quickly?
Oh, that's a good question. But I think straight away, it's about the quality of care that we provide for patients. I think it's their safety and it's the quality of care. If we don't get that right, and sometimes we don't, and we have to learn from that, but we have to make sure that that is the first thing right at the top of the list. It's about safety for patients and the quality for patients.
And I have to say, that's a refreshing bit of honesty to hear somebody at your level saying we don't always get it right. Mm. So, thank you for sharing that. On a personal level, what inspired you to embark on a career in healthcare? Where did it start for you?
Right. So I'm a nurse by background. Mm-hmm. And I've just given my age away a little bit, but I've actually been in the health service 41 years this year, which is a huge amount of time. Probably 3/4 of my career has been in nursing and working my way through a number of areas. I worked right across the south.
So you're not an administrator. You are a practical, hands-on, experienced healthcare professional.
I was.
Put it that way.
I was. I'm not now. I'm not now. Because, as you go up the ladder, it gets more and more difficult to be able to be hands-on and to be able to demonstrate that I still have those skills. I mean, it's very different from what I was doing 15, 20 years ago to what I'm doing now. It's interesting in the NHS. Things change quite rapidly, and you have a restructure of one sort of another, and that's how I ended up going into management and operations. And from that, I've then worked my way up, and I've been a chief operating officer at executive level, running divisions and quite large budgets for quite a number of years. I've done that about 3 times. And I've also been a director of strategy and a deputy chief exec. And then I came to support Medway 3 years ago, just only for 12 weeks. And 3 years later, here I am. And 2 years ago, I was made the CEO. So, but, you know, really pleased. Best job I've ever done, I would say. And it's very diverse. It's very different. Yeah, love every minute of it.
So having moved away from sort of the practical hands-on work that you've been doing, how do you keep in touch with what's happening on the front line? Because I imagine that's fairly difficult to do. There must be so many things taking your attention.
Yeah. Yeah. So it's very different from what I was doing before. But as you work your way up the sort of ladder, you have to make provisions so that you do keep in touch. And it is difficult. You know, some people say, well, she hasn't got a clue what's going on. But actually, there's different ways of doing it. I'm very, you know, most people have seen me around the organisation. Mm-hmm. We call it gembering. So that means go out with purpose.
Okay.
And so in my diary each week, there is always a slot, that I'll go out to a different area and go and see people, see how they are, what's happening, what's worrying them, and bring that back. And as an exec team and as a trust board, we talk about those. So every member of my team does the same thing.
So you expect them to go out and see for themselves what's happening on the front line. Yeah. And do you do that individually or do you do that as a team?
No, we do it individually. Yeah. Sometimes we take the non-executives with us if they're in. Sometimes we go together. It depends what we're doing. So, but we're clear and we normally let people know we're coming out of respect for them. Nothing worse than me just turning up. Although I do wander quite a lot around. But that's just to get a feel for the place. So it's not easy to keep in touch, but it's important that you see us out and about. And, you know, we can never do enough, I think, is one of those things. But there's other ways. You know, we have our staff briefings. We have a number of different ways of sending the messages out, but also getting messages back. Mm-hmm. And I think we need to do more of it. You know, so if people have got ideas about how we can improve that, I'm open to that.
Well, one of your channels might be through us, through Hospital Radio.
Through the radio, yeah.
That's something that's always available to you. What would you say are the core values that guide your leadership at the Trust? And has that changed since you've taken over? I don't know, what sort of trust do you feel you inherited?
Oh, that's it. Oh my.
If that's too leading a question.
Well, I think Medway Foundation Trust has had a bumpy few years. And because of a number of factors, I think, financially, I've said we've had a deficit for quite a long time, and that has an impact. You've got to have a plan to be able to get out of it. And I think we've got a good plan now and a lot of good support from NHSE and from the system and the ICB in order to do that. So I think that's one thing. I think also over a period of time, particularly when things aren't going well, there's a lot of chop and change. As someone said to me, you must be the longest running CEO we've had for a while, which is quite interesting considering it's only 2 years.
Well, I was going to ask you about that because when I interviewed James Devine, he told me that the average tenure was about 18 months of somebody in his position. And he suggested he was going to be around for a while and then he seemed to just vanish.
Oh.
But is that one of the issues that people aren't in place for long enough to see through the plans? Yeah,
because I think that is absolutely it. And it's the same with the senior leadership team, isn't it? In terms of my exec team, if you speak to some of the clinicians, etc., a chief operating officer, there's been 3 or 4 of them in a very short space of time. So this is about trying to stabilise the ship. Got a full team in now under my leadership. And that is so important. And we're not, as you go through, there's a lot to work through and we can't do it on our own. And we recognise that. But this is about working with the organisation, with the staff to really put the plans in place. So, for example, we didn't really have a clinical strategy up until recently. And we've just, with the help of the clinical teams, our chief medical officer has been leading that piece of work. And actually that was launched on the 10th of May, which is a really important statement about what we want to do as an organisation for our people going forward over the next 5 to 10 years. So it's that sort of thing that was missing, really, strategic direction.
That piece of work has been done. And what are the key things that have come out of that?
So the key things, we recognise that it sounds funny when I say it, but we're very emergency driven. So we have a lot of patients that come in that are not planned. And there's lots of reasons for that. And I think some of that's to do with the local system that we're in. We know that we haven't got enough GPs, for example. As a local health and care partnership, we are looking at the services that are provided out in the community to make sure that they are fit for purpose and actually they are doing what we need them to do. But as I say, we're very emergency driven. And so we have to look at that and say, how do we manage that? Yeah. So everyone knows, it's been very challenging for ED, for all EDs, particularly over these last couple of years. But this last sort of 6 months has been really hard for our staff down in ED and for our patients. But the work that clinical staff have been doing. So, for example, the introduction of the acute medical model.
Can you give me a bit more detail on the acute medical model? What does that mean to me as a layman?
So how that is, someone comes in, what are they presenting with? Do they need to be in the emergency department? Or actually, are they a medical condition that actually the acute medicine consultants can actually see and deal with and probably send home or bring back as an outpatient, or actually needs a very short stay in hospital. So it's very different rather than going through all the emergency department and a longer length of stay.
Okay.
So there are types of conditions that are absolutely ripe for going through that and being cared for that way. So that's one change that came in February.
So does that mean that you're kind of weeding out people and taking them away from ED when they don't need to be there?
When they don't need to be there.
What proportion of people present to the emergency department who really shouldn't be there in the first place?
I haven't got the figures off the top of my head, but there is a proportion that actually come to ED and then we say, actually, you're better we will stream you round to Medoc. So that is like a GP and nursing service because they don't actually need to be in ED. Or actually we could say, you're actually better going off to another service out in the community that can help and support you. There is a proportion. I haven't got it off the top of my head, so I won't say a number. But there is a proportion, and that is partly because of what I'm saying around the community services and also the GP provision.
So I'm guessing that some people end up in ED almost as a last resort because they can't sometimes some other way. How do you maintain links within the community, and what is your influence over the provision of services within the community? Because I imagine everything ends up on your front door, doesn't it?
It does feel like it sometimes, I have to say. I know my staff think that. Actually, there's some strong links that we have. We call it the Health and Care Partnership. So that's for Medway and Swale. That group is senior leaders of different organisations. So we play our part. That's me as part of the Acute Trust. There's the council, Medway Council, and Kent County Council is part of that as well, because they're covering the part up in Swale. We've got community providers, so MCH, and also HCRG have beds up in Swale, so and some services, so they actually are part of our group as well. But it gets wider than that. It's bigger than that. So it's not just with the council, etc. It's with voluntary services. There's other people that come into that equation, and we meet on a very regular basis. We have a plan for the system about what we want to do. And so we come together on a regular basis and we report through to the ICB.
Okay.
So at the centre, in terms of our region.
So where we might see the hospital perhaps being in isolation, you're not. You are part of a patchwork.
We're a partner.
Of organisations within the community, and you do all talk to each other by the sounds of what you're saying.
We do. Frequently.
Good. That all sounds like great stuff. What would you say are the biggest current challenges facing the Trust? I mean, there must be lots, but what's the thing that keeps you awake at night most?
I think there's a couple of things really for me. One is about we have been under extreme pressure at the front door. So from the emergency department, and we have had patients in the corridor and patients around the organisation that probably are not in the spaces that we want them to be, but we've had to try and maintain some of the flow.
Yeah.
That doesn't fit well with me. But as I say, the number of things that we've talked about about trying to resolve what's in our gift as an organisation to improve that flow is really, really important.
Yeah.
But as I said, we can't do that on our own, and we need our partners in order to do that. But it worries me, partly because it's about keeping that type of pressure on both, the staff themselves. And it's important we get that right. And it has been really difficult for them, regardless of where they are, but particularly in ED. But also it's about for the patients and the experience that they get. So that has been quite a challenge for us. And I think the other bit is around the money. Mm-hmm. It's about making sure that we spend every pound that we have in the best possible way. Even though we have a deficit, it's about making sure we've got that plan. Because if the NHSE at the centre's got confidence in us, then when we're asking for more or something different, then they will support that because they've recognised the work that we're doing around the financial position. But we have to work differently as a system and as an organisation, because right across the NHS, we haven't got the money at the moment. So we have to work in a different way.
And do you think that's likely to change, or do you think there will always be shortages of the funding that you need?
I think in 41 years, I don't think it's ever changed. But technology is helping.
Okay. Tell me a bit about some of the initiatives that you've put in place. I hear there's a fabulous new robot in one of your...
Yeah, we've got
areas.
two now.
We've got
two now. So, that's robotic surgery. So, the urology department put the first robot in a couple of years ago. But we've been lucky enough, we could secure additional funding that we could put a second one. Now that's really important for patient outcomes, and they've demonstrated that for particularly cancer patients, urology and colorectal. So what we want to do, that's part of the clinical strategy, is then expand that offer where it's appropriate for different patients. So into expanding colorectal, but even doing gynae and even others going forward. So that's been a really important initiative to do. I think some of the other things that we've seen is that you would have heard perhaps we've opened up Ruby Ward.
Yes.
So that's, we've opened up respiratory beds, and the high dependency unit piece that comes with that, and also some additional cardiac beds. And, I think most of the clinicians that've spoken to me, they've been waiting for about 15 years in order to do that.
Goodness
so
me.
That's a long time waiting for something, but
that's a very long time,
will make a significant difference. And it's a really exciting piece. We've got some more to do around cardiac. We need a second cath lab, but we are pushing to try and find the funding so that we can support that.
And where will that funding come from, most likely?
It could come from a number of places. It does pop up, I think, particularly centrally from an HSE when they are allocating different monies for either winter or for improvements, or it could come as part of our capital plan. So there's a number of routes that we can do that.
On the capital side of things, how much of a challenge is this site?
Yes, well, it's an interesting site, I think. We have got a big backlog problem, I think it's true to say. It's got some very old buildings, as you know where you are.
Yeah, we've had
your own problem.
We've had our own problems with a leaking roof, but that has been repaired, and we're now tight and dry.
Exactly. There's a lot of work to be done. There's the argument, actually, because we are landlocked, if you like, at the moment, because we've got housing all the way round and we're one site. Some of the plans that we want to do, particularly around the clinical strategy, we've identified a site elsewhere working with the council. And actually, if we can get some funding, again, we could lift and shift some of the elective. It's not very far away, but that would actually protect the elective work that we do. So day case, overnight stays, outpatients, that sort of thing. But it would release areas on the main site that we could then do something different with. I think often you will hear about, should we have a new hospital? Well, I think that's a different conversation. And actually at the moment, there's no mechanism for us to apply for a new hospital. But, given perhaps the population going forward, we mustn't take those conversations off the table.
And I'm presuming that you have links in with the planning people at the council that give you a heads up as to how that might grow. What are the challenges going to be in terms of population, do you feel?
Well, it's interesting. I think there's a number of things. It's an expanding population, and we know that additional housing is going up already, there are proposals for. So one of my teams working very closely with the council about, so what does that mean for us and our services going forward 5, 10, 15 years forward? So they are working on that at this moment in time. But I think it's also about the population and the health. Mm-hmm. And actually we've got to work very, very closely with public health about trying to do some of the preventative work and supporting some of that, which is so important. If you look at some of our cancer rates that we see, or the cancer patients that we have, they are quite late in presenting. So there's some work that we need to do with our population about how can we help you? How can we make sure you access services when you're not feeling well, mm-hmm. or you need some diagnostic tests? Now, you might have heard we've also got funding. We do get funding. This is the good bit, around community diagnostics.
Yeah.
And so we've started to open that up. One will be at Rochester and the other one will be at Sheppey. And that's really, really important about the population being able, and the GPs, etc., to be able to access those diagnostics earlier than perhaps they would have done just on the main site. Mm-hmm. So that's a fantastic initiative for this year and going into next. And so that will help us then speed up and hopefully see people at an earlier stage so that we can then give them treatment, etc.
And do you have any observations about the local population and how it compares perhaps with other regions in terms of, I guess, education and the public, us looking after ourselves?
Yeah.
Is it different here to other parts of the country, or would you say that it's broadly the same?
I think there's a bit of a mixture. We do have quite a number of pockets where housing's not great, income's not great, and actually, people accessing education isn't so good. So this is where the health and care partnership is so important. So all of us are working together to be able to address those issues. And I think, how do we then support those areas about making sure they can get healthcare, that actually they are getting the education? We are doing quite a number of pieces of work across the piece with education in terms of sixth form colleges and schools and things like that, which is so important because the earlier you start, the better it is.
And I guess the better habits that general public have, then the more healthy they're going to be.
Yeah, exactly. The system work is just as important as what we do through the hospital. And we have to be one of those partners, within that mix of dealing with some of that.
Yeah, because as I said before, I guess the ultimate place where the problem lands is very firmly in your lap.
Yeah.
My thanks to Jayne Black, CEO of Medway NHS Foundation Trust. Now join me in part 2, in which she talks about her management style and approach, as well as how the initiatives she's spearheading are supporting the 5,000 staff here at the hospital. She also discusses the impact of the hospital's patient-first methodology. And we find out a little more about the woman behind the title. To listen to more episodes or find links to all of our programmes and videos, visit hospitalradiomedway.co.uk. You've been listening to Chatterbox.
There's 4 easy ways to listen to HRM FM. Go to our website at hospitalradiomedway.co.uk and click to listen now. Go to NHS Wi-Fi on your device and find us there. Say,
play Hospital Radio Medway
to your smart speaker, or switch your radio on and go to 87.9 FM, the radio station for the Medway Maritime Hospital. This is HRM FM.